Yeah, guys, let's get into our common brain lesions. And first and foremost, let's talk about the frontal lobe. We'll try to connect the lesions with the areas of that brain performing that function. So first and foremost is our frontal lobe, right? So the frontal lobe basically is the lobe that controls your personality, right? So, whenever we talk about the frontal lobe, we talk about the area of the brain that controls your personality, not your heart, not your emotions. Basically, your frontal lobe is the area of the brain that controls your personality. Okay, I've said this 3 times. It should be inherited, it should be imprinted in your brain by now. It is responsible for judgment, for decision making, for planning, personality, concentration, social behavior, impulse control. So it's basically the largest cortical region of the brain, comprising approximately 40% of the cerebral cortex. It's responsible for various functions, as I said, that include motor control, speech, executive functioning, behavior, basically your personality area. It contains distinct areas such as the medial frontal region, the dorsolateral region, and the frontopolar region. Now, I don't need to get into so much details about this, but I will punch a picture here for you guys to look at the frontal lobe, right? So we're talking about this frontal area here for now, right? So a frontal lobe consequence of lesion in a frontal lobe will be this inhibition and deficits in concentration, orientation, judgment. Judgment is your most clueful word and may have the emergences of primitive reflexes. Now, what do we mean? Primitive reflexes are reflexes that babies have, right? So these are like grasp reflex, rooting reflex, snout reflex. So adults should not have them. But imagine if an elderly patient suddenly starts showing like the thumb, he's sucking his thumb or she's sucking her thumb. Now this is a root, this is like a reflex that only babies do, right? So you think about a frontal lobe region. The disinhibition of this area will lead the person to become very impulsive, rude, inappropriate, and childish. This is called disinhibition. They lose concentration. They have poor judgment, poor planning, and sometimes primitive reflexes come back, right? A clinical example I would give you, imagine a businessman, he's very polite all his life. Suddenly he starts making inappropriate jokes and touches strangers and cannot manage finances. He gets lost, right? This is frontal lobe damage. Now we talk about frontal eye fields. Now this is the destructive lesion, right? Destructive lesion of the MCA stroke, for example, the middle cerebral artery stroke. Eyes look towards the brain lesion, or that is basically away from the side of the hemiplegia. I'll show you the middle cerebral artery blood supply, right? So when we talk about these, so can you see how the anterior cerebral artery supplies the most medial portion and the middle cerebral artery supplies all the other portion? Basically, most of the brain is supplied by the middle cerebral artery, and the posterior cerebral artery only takes like the inferior and medial and some of the lateral region, right? Can you see this? So this green area is basically your middle cerebral artery. So look at the middle cerebral artery. It controls so much of your brain, right? Right? And the anterior takes the superior most portion and the posterior takes the inferior most posterior and inferior surfaces, right? So remember that. Let's go back to our brain lesion. So we were discussing about our frontal eye fields, right? So in a middle cerebral artery stroke, it's very common to get a frontal eye field defect. And whenever you get a frontal eye field defect, it pushes both eyes to look towards the opposite side. So the right frontal eye field looks to the left, and the left frontal eye field looks to the right. Now, suppose the left MCA stroke damages the left frontal field, right? It can no longer push the eyes to the right. So the right frontal eye field is now stronger. So both eyes drift left, and they basically drift towards the lesion away from the weak side, right? Away from the side of the hemiplegia. I hope that's easy for you to remember, right? So whenever you ever get in an exam, whenever you get a destructive cortical lesion, the eyes look towards the lesion away from the hemiplegia, right? Because the other one is working strongly now. So always look at the lesion and the stroke destroys the cortex and eyes look towards the damaged side. Remember that, okay? Now we have the paramedian pontine reticular formation. This is also known as the PPRF, right? PPRF. This is the horizontal gaze center, right? Um, all right. So continuing off from where we left off, basically, so we were discussing the paramedian pontine reticular formation, right? So the difference between a frontal eye field lesion and a paramedian pontine reticular formation is that in PPRF, the eyes look away from the brain region, that is towards the side of hemiplegia, and the frontal eye field, it was the opposite. Right now, why does this happen? Suppose the left PPRF is damaged. The patient cannot look left. The intact right side pulls eye on the right. So eyes look away from the lesion towards the side of the hemiplegia. So remember that, right? So frontal eye field lesion, you look towards the lesion. For PPRF, you look away from the lesion, right? Moving to on to our next lesion, that's the medial. Remember, always remember this, right? So one stroke, but you have opposite answers, right? If it's a frontal eye field defect, the eyes look towards the lesion, away from the hemiplegia. If it's a PPRF lesion, the eyes look away from the brain region towards the side of the hemiplegia. This is the frontal is away and the paramedium is towards the side of the hemiplegia, right? Okay, moving on to the medial longitudinal fasciculus. Um, all right, so remember we talked about the medial longitudinal fasciculus. It's a paired, heavily myelinated nerve tract located near the midline of the brainstem. So you have the MLF here, right? It basically lies in the midline of the brainstem. It takes part of the midbrain pons and upper medulla here. So you have the midbrain pons and upper medulla here, right? Um, okay, so basically it connects the nuclear cranial nerves that are involved in the eye movement. Its main role is to coordinate conjugate horizontal eye movements, and how it does that is basically interconnects the abducens nucleus, right? So it connects the abducens nucleus, it connects the oculomotor nucleus. This MLF basically here you have the oculomotor nucleus. It also connects the abducens nucleus, also the trochlear nucleus. It connects the trochlear nucleus also here. This is the trochlear nucleus, right? Um, and also it connects the vestibular nuclei. So also the vestibular nuclei, it also connects the vestibular nuclei. So you can see these vestibular ocular fibers here. You can see the vestibular ocular fibers here also, right? These are the vestibular nucleuses, the medial and inferior vestibular nucleuses. So basically, the only one you can't see here is the abducens one, right? So it connects the oculomotor nucleus, it connects the trochlear nucleus, it connects the vestibular nucleus, and it connects the abducens nucleus. So all of this connection basically allows both the eyes to move together in the same direction, right? So when looking to the left, when you're looking to the left abducens nucleus stimulates the left lateral rectus. Through the right MLF, it sends signals to the right oculomotor nucleus, causing contraction of the right medial rectus. Both eyes move left simultaneously. So all this horizontal gaze is basically connected using these MLF fibers. So whenever the clinical significance would be internuclear ophthalmoplegia. A lesion of the MLF causes internuclear ophthalmoplegia, and that would be the signs would be impaired adduction of the eye on the side of the lesion, right? So on the side of the lesion, there is impaired adduction of the eye, nystagmus of the abducting contralateral eye. Convergence is usually preserved unless the lesion involves the oculomotor nucleus. So abduction and adduction are affected on the both eyes, but the conversion is usually preserved unless the ocular nucleus is also involved in the disease. Common causes will be multiple sclerosis or like a brainstem stroke or ischemia, and less commonly, sometimes in trauma, tumors, and infections, you get this, right? So let's go back to our table and look at what they've told us about medial longitudinal fasciculus. This is internuclear ophthalmoplegia, impaired adduction of ipsilateral eye, and nystagmus of the contralateral eye with abduction, right? So in the side of on which the lesion is present, there's impaired adduction of the ipsilateral eye. So your eye cannot come in the center, in the near your nose on the side of the lesion. But on the other side, there's nystagmus of the contralateral eye. The eye is going to like hesitate in its position, and it is also going to be abducted. It was going to look towards the lateral side. Okay, that's something about the MLF. I told you it's a communication table between this abducens, oculomotor, vestibular nucleus, and which one did I miss out? The trochlea, right? Suppose I've talked about this, right? Internuclear ophthalmoplegia. It's very high yield. You get cases like a young woman who has double vision, and this is basically you get multiple neurological symptoms. You think about multiple sclerosis. Why? Because multiple sclerosis loves demyelinating long white matter tracts, and MLF is a very heavily myelinated tract, and multiple sclerosis definitely firstly affects the it long white matter tract. So it loves demyelinating long white matter tracts, right? So in MLF, you can remember my left eye fails to adapt. That's how you can just remember how to remember the disease in this. So my left eye fails to adapt. That's how you can remember MLF, right? Okay, so moving on to dominant parietal lobe, right? Let's go back to our brain and look at the parietal lobe. So this is your parietal lobe, right? You have the somatosensory association area, the reading area, the speech and taste area. Also, the somatosensory cortex lies in the parietal lobe. So the dominant parietal lobe is usually the left hemisphere, right? So in people who are usually righties, they have the dominant parietal lobe is basically the left hemisphere. This is the usually the left hemisphere is dominant. This region integrates language with calculation and writing, right? You know how we say like the lefty hair, right hair. So damage produces Gerstmann syndrome. Gerstmann syndrome has four findings, and you can just learn them, right? The first thing is agoraphobia. Agoraphobia, you know this word, agoraphobia basically means you cannot write, right? Acalculia means you cannot calculate. Finger agnosia means you cannot identify fingers, and left-right disorientation means you cannot identify what's right, what's on the left, right? So the patient cannot write, the patient cannot count his fingers or tell him his fingers from the other. He cannot calculate, and he doesn't have any right or left identification. Like he cannot recognize left from right. He cannot sign his name. He cannot subtract because he cannot calculate, right? So think about a dominant parietal lesion, and this is basically very commonly found in Gerstmann syndrome. Then you have the non-dominant parietal cortex also, right? This is usually the right hemisphere. This side pays attention to the world. So a damage to the non-dominant parietal lobe will lead to the patient ignoring his left side. This is not blindness, right? This is usually the non-dominant is usually the right hemisphere. So problem the non-dominant is usually the right, basically usually the right one, right? So problem with the non-dominant will lead to problems on the left side, right? So the patient literally doesn't realize the left side exists. This is not blindness. Like the patient is not blind, the patient ignores the left side, right? Example, he will eat only right half of his plate and shave only right side of his face and draw like half of a clock. He ignores his left arm altogether. This is like hemispatial neglect. We call this hemispatial neglect, right? So it's a hemispatial neglect syndrome. There's agnosia of the contralateral side of the world, like it doesn't even exist for him. It's not like he's blind or anything. Then we have the hippocampus. Hippocampus, we've already told you so many times that the hippocampus is basically the memory center, right? The old memories in hippocampus problem, the old memories are mostly preserved and the new memories cannot be formed, and we call this anterograde amnesia. So there's an inability to make new memories. The patient introduces himself every 5 minutes. I saw a movie in which the woman would wake up every morning and her husband really loved her, so he would explain every morning to her that, oh, you're my wife and I'm your husband, and we've been this, we've been together for so many years, and we have a daughter. And like, I mean, the movie that I saw, she doesn't get cured from it, but it was really sweet how she found this person who loved her so much to explain her life to her every day in the morning. So that's basically your hippocampus, right? Anterior brain amnesia and your ability to make new memories. Then we have basal ganglia. This is the movement control center. It smoothens out movement, right? The basal ganglia, it's like this beautiful stroke of paintbrush. So you give the paint and you give all this raw material of movement, but the stroke of the artist's brush will tell you that this is painted by that artist, right? So basal ganglia is like this that person who smooths out the movement, right? So a damage of the basal ganglia is going to lead to all the unsmoothing movements, all the unsmoothened movement. It will give you tremor at rest. It will give you a chorea that's like a very funny, weird dance movement. Not to make fun of it, but that's just how you can remember. And athetosis. all of this basically points towards your basal ganglia lesions. You see this in Parkinson disease, in Huntington disease, in Wilson disease, right? Parkinson, because Parkinson damages like the Niagara striatal pathways. It leads to the um, dopamine being gone, right? So Parkinson basically means that there's not enough dopamine, right? The substantia nigra compacta degenerates, right? We saw this. Then we have so patient basically has a bradykinetic, rigid resting tremors and shuffling gait and mask-like face. And then Huntington is basically where the brake was destroyed, right? So you lose neurons inside the striatum. And which neurons? The GABAergic neurons of the indirect pathway die first, right? So the brake disappears and the accelerator wins, which was basically when they die, the indirect pathway disappears, right? So the brake disappears and the direct pathway gets like super activated. So you get this too much movement, right? This chorea, dance-like movements, and dementia and psychiatric disease. In Huntington, you were seeing the CAG repeat on the chromosome 4, and you were seeing anticipation with further generations, and this was autosomal dominant. Wilson disease. Now, a little bit about Wilson disease. This is like copper poisons on the basal ganglia, right? So this is not the problem. It's not dopamine. You have this ATP7B mutation. The copper cannot leave the liver. The copper accumulates in the tissue, and one favorite place for it is the basal ganglia, especially the putamen, globus pallidus, and caudate, because the copper is toxic. It kills the neurons. So patients can have both. In Wilson, patients can have too little movement, which is a little bit like Parkinson, or they can have too much movement, which is basically like tremor, dystonia, and chorea because multiple basal ganglia circuits are injured, right? So you can have like in these three diseases, you can have in Parkinson, it's always like bradykinetic rigidity, right? Shuffling gait. In Huntington, it's always like dance-like. But in Wilson, you can choose which one you're going to look like more, right? You never know which one to expect. Okay, moving on to the subthalamic nucleus. I told you the subthalamic nucleus basically I remember telling you that the subthalamic nucleus was releasing a hormone called the glutamate, right? So the glutamate was the excitatory hormone. The subthalamic nucleus sends these excitatory glutaminergic signals to the internal segment of the globus pallidus, right? So the globus pallidus was subthalamic nucleus makes the glutamate. It sent it with it, which was an excitatory hormone. It sends it to GPI of the basal ganglia, which sends like GABA, which was acting like an inhibitory signal to the thalamus, and that goes to the motor cortex. So the net effect of the subthalamic nucleus is to increase inhibition of the thalamus, which means it reduces movement. You can think of it as the brain's braking system, right? That's just a little revision for you of what the subthalamic nucleus was. A lesion of the subthalamic nucleus will basically cause hemiballismus, right? So hemiballismus is where the patient throws one arm violently, large flinging movements on the contralateral side because the motor pathways cross, right? So you think about billismus, you think about this ballistic missile of an arm, right? And then we have the mammillary bodies. This is very commonly tested in exams. These are memory relay stations that they require B1 for functioning, right? So they need thiamine for functioning. Alcoholics have poor nutrition, so they get a thiamine deficiency, which leads to Wernicke encephalopathy. You get confusion, ataxia, and ophthalmoplegia. And this confusion, ataxia, and nystagmus or ophthalmoplegia, if untreated, leads to Korsakoff syndrome, where the patient develops memory loss, confabulation, and personality changes. Confabulation, what is confabulation? Basically, it comes up a lot in the exams. It's when the patient lies without intending to. Like the patient doesn't want to intend on lying, but he just lies because the brain fills the memory gaps, right? That's confabulation. Okay, so you have the Wernicke-Korsakoff syndrome. It leads to confusion, ataxia, nystagmus, ophthalmoplegia, memory loss, anterograde and retrograde amnesia, confabulations, and personality changes. That's your memory bodies, right? They're present bilaterally. And then you have the amygdala. Amygdala is also present bilaterally. This is the fear center or the aggression center, right? Emotional center. That's like if the amygdala is damaged, it's like a person will see a snake and not be scared. He'll be so calm, and that's weird because his amygdala is damaged. This is like bilateral destruction of amygdala is basically seen in Kluver-Bucy syndrome. In Kluver-Bucy syndrome, the patient becomes fearless, hypersexual, hyperoral, and he'll start licking anything, like literally anything, but like kids do, because his aggression and fear and emotion center is like um lesion. He becomes docile and he sees this visual agnosia. And the most common cause, by the way, is HSV encephalitis because HSV loves temporal lobes, right? And the amygdala is part of the temporal lobe, right? Now we have the dorsal midbrain. The dorsal midbrain basically produces the Perinaud syndrome, and this is usually due to pinealoma or hydrocephalus or stroke, right? Um, Now, the classic findings of a Perinaud syndrome is when you cannot look upward, there's a vertical gaze palsy, and there is light near dissociation, lid retraction, and convergence retraction nystagmus. In exam, you would see like this teenager who has a pineal tumor, he cannot look up, and you think about Perinaud, right? That's your Perinaud syndrome. Then you have reticular activating system, this one, like the reticular activating system, the midbrain, reduced levels of arousal and wakefulness. I told you the reticular formation was related to the arousal and wakefulness, right? And lesion would lead to reduced levels of arousal and wakefulness in the midbrain. This keeps you awake. Think of it as the brain's on switch. A damage will lead to a patient not staying awake. Severe damage is going to lead to coma. A simple rule is that the reticular system keeps you awake, and damage will lead to coma. Then we have the cerebellar hemispheres. We had two cerebellar hemispheres on both sides, right? Cerebellar hemispheres are basically controllers of the same side. The cerebellum controls the same side, unlike the cerebrum. It's not crossed, right? The same cerebellar sides controls the same side of the body. A lesion causes like a lesion of the cerebellar hemisphere, the same side would cause like ipsilateral intention tremor, ataxia, dysmetria, loss of coordination. Patient falls towards the lesion. Why toward the lesion? Because the same side is being affected, right? Cerebellar hemispheres are laterally located. They affect lateral limbs. Cerebellum talks to the opposite cerebrum, and then motor pathways cross again. So two crossings means the deficit ends up being ipsilateral, right? That's what I want you to remember. Okay. Then we have the cerebellar vermis. This was the area in the middle. It was centrally located. If you remember, this was like the midline part of the cerebellum. It controls balance, posture, walking, and trunk muscles. So you have truncal ataxia and cerebellar vermis conditions, so like the drunken sailor gait. Nystagmus is seen. You get a wide-based gait. There's truncal ataxia. The patient cannot sit steadily. He falls in all direction. You think of a drunk person. That's why we're calling it a drunken person gait. Alcohol preferentially damages the anterior vermis in chronic alcoholism, right? The anterior vermis is very commonly damaged in chronic alcoholism. That's something to remember for alcoholics. And then we have the red nucleus. We've already done the red nucleus tract in a separate class, so I don't know if I want to revise that here because it will take too much time and I want 22 minutes. This is an important concept. Basically, the red nucleus acts like a dividing line, right? So lesions above the red nucleus give you a decorticate posture, and lesion at or below the red nucleus give you a decerebrate posture, right? Decorticate posture, a lesion above the red nucleus will give you a decorticate posture, and that's when arms flex, legs are extended, hands come towards the heart. So you can remember decorticate towards the core, which is your heart, right? That's one way of remembering it. And below the red nucleus, it's a decerebrate posture. This is when everything extends. Arms extend, legs extend. This indicates a more severe brainstem injury and generally it carries a worse prognosis. So we'll stop with the brain lesions here, and I hope this video was not too long.